Anaphylaxis, recognition, pathophysiology, and life-saving management. A 28-year-old woman is stung by a bee at a picnic. Within minutes, she develops hives. Her throat feels like it is closing, and she collapses. Her blood pressure is 70/40. What is happening, and what do you do in the next 60 seconds? Welcome to Medical Sciences Unfolded. Anaphylaxis is the most severe form of allergic reaction, a rapidly progressive, potentially fatal systemic hypersensitivity response that demands immediate recognition and treatment. Let's start with the immunology. Anaphylaxis is a type 1 hypersensitivity reaction. On first exposure to an allergen, a bee venom protein, a peanut antigen, a penicillin molecule, the immune system generates IgE antibodies that bind to high-affinity receptors on mast cells and basophils throughout the body. The individual is now sensitized. No symptoms occur on first exposure. On re-exposure, the allergen cross-links these IgE molecules on the mast cell's surface. This activates intracellular signaling cascades that trigger immediate degranulation. The mast cells burst open and release their preformed mediators, histamine, tryptase, heparin, and proteases. This occurs within seconds. Simultaneously, newly synthesized mediators are produced, prostaglandins, leukotrienes, and platelet-activating factor. The effects of these mediators are systemic and simultaneous. Histamine causes vasodilation and increased vascular permeability. Plasma leaks from blood vessels causing edema. In the skin, this appears as urticaria and angioedema. In the airway, edema of the larynx and epiglottis causes stridor and life-threatening upper airway obstruction. Histamine also causes bronchoconstriction, wheezing, and respiratory distress. Leukotrienes amplify and prolong bronchoconstriction. Prostaglandins contribute to vasodilation and airway inflammation. The cardiovascular collapse of anaphylaxis, distributive shock, occurs because massive vasodilation combined with fluid extravasation reduces venous return and preload. Cardiac output falls. Blood pressure crashes. The patient becomes hypotensive and can develop cardiac arrest within minutes. Not all anaphylaxis requires prior sensitization. Anaphylactoid reactions, such as those to radiocontrast media or NSAIDs, cause direct mast cell degranulation without IgE involvement and are clinically indistinguishable. The clinical diagnosis of anaphylaxis requires at least one of three criteria. First, acute skin or mucosal involvement, hives, flushing, angioedema, plus respiratory compromise or hypotension. Second, two or more organ systems affected within minutes of allergen exposure. Third, hypotension alone after known allergen exposure. Common triggers: foods, peanuts, tree nuts, shellfish, milk, eggs are the leading cause in children. Insect venom is common in adults. Drugs, especially beta-lactam antibiotics, NSAIDs, muscle relaxants, are a major cause in medical settings. Latex, exercise-induced anaphylaxis, and in up to 20% of cases, idiopathic, no trigger is ever identified. Treatment: epinephrine is the only first-line treatment for anaphylaxis. Nothing else comes first. The dose is 0.3 to 0.5 milligrams of 1 to 1,000 concentration intramuscularly, injected into the outer mid-thigh, the vastus lateralis, where absorption is fastest. Epinephrine works through alpha-1 receptors to cause vasoconstriction, reversing hypotension and reducing mucosal edema. Through beta-1, it increases heart rate and contractility. Through beta-2, it causes bronchodilation, countering bronchoconstriction. Common error: giving antihistamines or corticosteroids first. These drugs do not treat the life-threatening features of anaphylaxis and should only be given after epinephrine as adjuncts. If hypotension persists after epinephrine, lay the patient flat with legs elevated. Give rapid IV fluid bolus, 1 to 2 liters of normal saline. Repeat epinephrine every 5 to 15 minutes as needed. Nebulized albuterol for bronchospasm. IV diphenhydramine and ranitidine for urticaria. IV methylprednisolone to prevent biphasic reactions, a second wave of anaphylaxis occurring 8 to 72 hours later, seen in up to 20% of cases. For refractory hypotension unresponsive to epinephrine, especially in patients on beta blockers who block epinephrine's beta effects, IV glucagon is given. Vasopressors may be needed. Secure the airway early. If laryngeal edema is progressive, intubate before complete obstruction. Have a surgical airway kit available. All patients who receive epinephrine must be observed for at least 4 to 6 hours for biphasic reaction. At discharge, every patient gets a prescription for an epinephrine autoinjector, EpiPen, and must know how to use it. Allergy referral for skin testing and venom immunotherapy if appropriate. This is not a scare tactic. It is survival education. Thank you for watching Medical Sciences Unfolded.